Okay, so I'm just going to get started just in the interest of time. And if people join us, by all means, I will admit them as they join. So welcome everybody to our second session of the National Curriculum Seminar Series. I'm delighted to be here with you all today. I am really excited about this particular topic today. We're going to have Dante, or Dr. Dante from McMaster, talk to us about neurostimulation. And he is an assistant professor and geriatric psychiatrist at McMaster University in St. Joseph's Hospital. And he has an MD and PhD with training in Brazil in the United States. And he also did a 3-year postdoctoral clinical research fellowship at Harvard Medical School in Boston. So welcome. We're so excited to have you. And let's get started.
Yeah, thank you, Catherine, and thank you all for today. And I hope you guys would like my presentation. I will hopefully able to share my presentation here. Yes, can you see, Catherine?
You can see it, thank you.
Let me see if I put on slide mode. Yeah, now, okay, so the topic of the presentation today is about neurostimulation. I know most of you, I have several residents that rotate here with me in the geriatric psychiatry units division. You in your training, you oftentimes there's no dedicated time to discuss about neurostimulation. So you guys do a little bit of rotation. At least my students in McMaster, they do a little bit of a rotation in ECT. But other than that, it's not a long exposure. And I wanted to discuss, and I will perhaps have 35 minutes here with my presentation, and perhaps we can have some Q&A, and you can ask me questions, because I think we are getting to an exciting time before I start, where the standard of care for several conditions, they are not working as we would like. We were discussing yesterday with a group of residents what to do with a patient with early dementia or even MCI and apathy, for instance. Some studies showing that methylphenidate could be used, but we know all the side effects. So at the end of the day, our standard of care is not as effective as we would like. Sorry, there's a little alarm here in my building. So I have no conflict of interest at all. So the roadmap of my presentation today is to give you just a brief overview about different modalities of brain stimulation, and getting a little bit of more the mechanism about TMS, but more particularly the deep TMS, which is the new approach, which is it's a new development of the TMS. Clinical indications, I'm going to be talking about the differences, the clinical indications, and the promising research area. So about the history, back in 43 before Christ, we have some reports from that book, Compositiones Medicamentorum, that people were already trying and attempting to use electricity as a treatment. So as you see here, this is an electric ray. They put that on the head of a patient and to try the electrotherapy for headache and gout. I would say those who didn't die, they would then perhaps get better, right? Or worse. Anyway, in our society, we have always been interested in using electricity. This is something that we were always excited about. And you can see here, Duchenne had a textbook on electricization. I even don't know how to pronounce that. And you can see on the right side, Dr. Sanders' electric belt. So Dr. Sanders offered an electric belt for weak men, that you would wear the belt, and that would have for who are debilitated, suffering from nervous debility, seminal weaknesses, loss of drain, impotency, helminthism, kidney problems. So Dr. Sanders offers brain stimulation for everything. So moving ahead, we then with Faraday and some other scientists, we then began to control the magnetic field and also controlling the electric field. Faraday, with his theory or theorem, said that a very variable magnetic field generates an electromotive force. As you can see here, the magnet in a brush, and then once you do the you run the brush, then you have an electric flow in that wire here, generating an electric field. This is very simple as the battery down here on our right bottom here. That this is the experiment we always do when we are kids with the battery. So, but with that theory that was proposed by Faraday, Dr. Armstrong tried to actually put someone inside a coil with magnetic field. So actually trying to understand what is the actual effect of a magnetic field in your brain. So that person had the intensity of 30 amperes with a frequency of 42 cycles, and they were able to see phosphines and vertigo in his head, which again was not very effective for anything. But later on, then coming back to the modern times, 1985, this scientist from England, Dr. Barker, in 1985, was then the first one who developed this TMS machine. It's a magnetic stimulator, as you can see here, with a coil. And that coil placed on the head of a subject, you can then have biological effect. At that time, he was trying or aiming to show some biologic effect caused by the magnetic field coming from that coil. And then from that, there's this jump from now the modern TMS. On the left, there is the traditional TMS, as we call today. When you read an article, or if you've been exposed to, this is the traditional TMS that we know. There's a figure of 8, which that figure you place on the head of a patient, and that figure generates a magnetic field that I will show in the other slide. But you also have now, from some years from now, what I would say an improvement of the traditional TMS, which is the deep TMS. Instead of having a figure of 8 coil, you have a much more complex constellation of wires where you can go deeper in the brain, much deeper than the traditional TMS. What are other options of brain stimulation? And here I will only cite some that perhaps you've been exposed to or you know already. So on the left, you have transcranial electrical stimulation, which I will show 2 pictures. You have in the middle the transcranial magnetic stimulation, as I was talking about, and you have an invasive stimulation on the right. And then this stimulation, you can say the vagal nerve stimulation. You can also go as deep as to the ganglia basa, and some studies with Parkinson's disease are showing that you can place electrodes with the deep brain stimulation. This is some images that from that device I mentioned about, the transcranial direct current stimulation. You can actually place the electrodes over patient's head. You have a positive and a negative pole, and the current goes from one side to the other. Is a weak current that if you practice that same cortical network that you are stimulating on, it's thought to be to produce more of a neuroplastic effect. So here you have some rehab people doing stimulation while they are doing the exercise. And this is another modern device that delivers transcranial direct stimulation, but combined with EEG. So while you are getting the stimulation, you are also getting your brain waves measured. So basically, you know where the field is going, and you also know the biological effect in a real time. This device is a neuroelectric device we used to use in Boston when I was working there. It works really well, and it does have we acquire a lot of data from a biological standpoint and a neurophysiological standpoint. Coming back to the same slide, so now I'm going to talk a little bit about TMS and deep TMS, because these are the most used. And I think having a little bit of more understanding about the mechanism and some indications and the clinical trials, perhaps I would add some information to you. So basically, this is a summary of the mechanism of a transcranial magnetic stimulation. It's from that standpoint, it's simple to understand. It's a magnetic field that is generated by the coil, as I said. So you guys are familiar with MRI, magnetic resonance imaging. We use 1.5 Tesla in an MRI as well. The difference between that coil and an MRI is that MRI is a much longer time. Here we are generating the same energy of an MRI, but in milliseconds. So, and it's really quick. So you are actually generating a strong pulse, but it's in millisecond. And that pulse generated from the coil gets then through the scalp and then reaches the brain tissue. And if you go down here, it triggers an axon to really triggers an action potential. With an action potential in a rhythmic way, you can have a neurobiological effect. If you come here to the right side, you have the coil, and then you have what we call eddy current. Eddy current means a magnetic field in contact with your neuron cells generates an electric field, and that electric field has the direction, it's perpendicular to the magnetic field, and does induce, it triggers neuronal signaling through action potential. So you can see in the bottom of the figure, there is actually one action potential being generated by the magnetic field. So if you go more molecular, from a molecular standpoint, where we want to reach? We want to reach the brain region that has more neurons, we call external pyramidal region, which is layer 3. This is just to say that you can't just place the coil wherever you want or tilt the coil the direction you wish. You need to be very cautious and careful, because you want to reach the sulcus of the brain, of the neural cells, of the tissue, where the stimulation is more efficient when it's perpendicular to the scalp, but then you wanna go a little deeper and to the sulcus, where you can trigger and target more neurons. And I think good research, when you are offering an indication of a treatment, it's always important to know what an animal model shows, right? You just don't jump to humans. So this is one, I'm just showing 2 studies. This is one of the studies. You can see here a magnetic. Catherine, can you see my pointer here? Okay.
Yes.
So nice, thank you. So there's the magnetic coil here, and then the mouse, with a little 2 electrodes, as you can see here. So we are doing EEG while we are stimulating. And the beauty of these studies, a neurophysiological study, is when you are actually stimulating and post-stimulation, you have a rhythmic response with the action potential. So we were able to evoke a biological response that is rhythmic, and we would then change the excitability of these mouse neurons. And this other study was really interesting as well, just showing that when you have so let me explain first. So this is the coil in the middle, and there is a isoflurane system where we applied anesthesia, not we, the authors applied anesthesia. So the mouse was under anesthesia, and it received 10 daily sessions of rTMS versus sham for 10 days. So 10 daily sessions. The research question here was, is there any substantial neuroplasticity marker? Is there a neuroplastic effect of stimulating an animal's brain? And the authors, they did show that after 10 sessions compared to placebo, the animals that received high frequency TMS had a higher level of BDNF in the tissue as compared to a sham and as compared to low frequency, indicating that hippocampus and prelimbic cortex had a higher expression of BDNF, which is, as you know, it stands for brain-derived neurotrophic factor, which is associated with increasing synaptic and an increasing of neuroplastic effect or neuroplasticity effect. And just summarizing then, what are the neuroplasticity effect that TMS would do in a molecular level? It's what we call long-term potentiation. So as you come from the left to the right, so here is a neuron in the synaptic level. In the left, you have the the vesicles, and in the right, the receptors. So if we go for before long-term potentiation induction, you have the neurons as they are. And then here during when you are evoking, when you are giving the transcranial magnetic stimulation, you are actually increasing the signaling, increasing the influx of calcium, and also increasing the vesicles in the presynaptic neuron. And in the postsynaptic neuron, you are increasing the calcium influx. And after the stimulation, it has been shown that the presynaptic neuron has much more increased vesicles of neuroamine, and the postsynaptic neuron has then more receptors, and therefore we then call that long-term potentiation, which stands for a more increased signaling in the synaptic, but more solid synaptic binding. Not only the signaling is increased, but also the synaptic binding is a little more solid. So summarizing the mechanism, what we know so far, what we know about TMS so far, we know that increased brain excitability and functioning. And then some of you can ask, but how do you know that? We know not only by animal studies. We are now to the point that we were able to show in functional MRI studies, as you can see in your bottom left, increased blood flow, increased activation, and also increased connectivity in some networks. But also we can show on your right now that TMS, the biological effect could also be measured with EEG, showing an increased brain excitability. You increase the monoamine turnover as well. We're talking here about serotonin, dopamine, and noradrenaline, increased BDNF. And some studies shows that there is a normalization of the axis, the HPA axis. And here is a figure that just to show you, when you read in the literature or when you read the news or when you talk about deep TMS, right? What that stands for. So then you have an H1 coil in the left. This coil, as you can see, is much more deep and complex than a figure of 8 coil. And this there is FDA and Health Canada indication for depression. It targets the bilateral prefrontal cortex with a predominance to the left. There is another indication that has been cleared for FDA cleared and Health Canada cleared, which is the H7 coil. It's a little different for OCD. And I'm going to just showcase the papers. But that would target the medial prefrontal cortex and cingulate cortex. And there's the new indication that everyone is excited about, which is the H4 coil for smoking. Yeah, with very interesting results. Fortunately, the hospital here just bought a deep TMS, and we'll be able to also show, try to test that in some clinical trials. And it is thought that this H4 coil goes to the insula and prefrontal cortex as well. And this is the right one, is the traditional TMS, the figure of 8, still effective, but much more superficial. That doesn't go to the deep structures, and you can't actually claim that you go to the deeper. So in your right hand side in my presentation, you have the FDA cleared, some initial efficacy, sorry, for alcohol. You all know, we are in Canada, cannabis is legalized, so it's legal. And then there are some studies starting to try the intervention of the H4 in patients with cannabis use disorder, with early efficacy, very interesting. And in Europe, there are some CA market, which means early approval for Alzheimer's, bipolar, PTSD, and chronic pain. Early signs of efficacy, not cleared yet. What is the main difference? Is exactly that. Why go to deep TMS? Because why purchasing a much more expensive device? Because it goes deeper, and it's more reliable because you don't change a lot, and it's more broad effect. And the deep TMS engages broader regions and reduce target errors. If you can see here, the traditional TMS coil, it gives you a little, the stimulation goes, as you can see here in red. This is the left dorsolateral prefrontal cortex, because the patient is looking at the direction of the screen. And when you stimulate with the deep TMS, you can see that you have a much broader and deeper structures that it's getting activated. And this is also a study comparing both in patients, 228 patients with depression, 20 sessions of H1 versus 8 coil. Both groups were exposed to standard of care. The pharmacotherapy, they were unchanged, versus only standard of care alone. So 3 groups. And the primary outcome was the proportion of patients achieving response. So comparing 3 groups, the proportion of patients that were to achieve response was defined as a 50% decrease in the Hamilton 17 at the 4th week. As you can see, the comparison between the 3 groups, the group that received the deep TMS had an increased, a higher response rate of 1.74 in the odds ratio of H1 coil compared to the 8, and of course compared to the sham or the tradition or the placebo was much higher. We'll just cite some studies here, just go over the indications so that you are more familiar with the literature. The deep TMS for major depression. This was the study that had the FDA clearance. It's the efficacy and safety of deep TMS for major depression. They performed a double-blind, placebo-controlled, multi-center trial with 212 subjects, and again 12 daily sessions over the prefrontal cortex bilaterally, and then they had a bi-weekly for 12 weeks. So it's a long treatment, right? The patient would come for 4 weeks, 5 treatments daily, and then would follow up other 12 weeks. The primary outcome was change in depressive symptoms after the 4th week. So at the end of the acute series, at the end of the 20 sessions. And again, if you see this graph, this figure, I'm not sure if everyone is able to see, but the blue, it's the sham. Sham means, perhaps I should spend 30 seconds here explaining sham. So sham, it's a placebo coil. So you have the same coil, and it delivers like a pressure in your head and the noise, but there's no magnetic field there. So the patient and the examiner, they can be blinded. It's just a matter that when you set up the machine, you can just input a code. If I'm operating the machine, the device, I can just have a code. I don't know if that is the sham or the active. The device delivers the sham mode and the active mode. So and then so this trial then at the week, here is week 5, but it means at the end of the 4th week, you have then a reduction of 6.39 points in the group that received the active deep TMS. If you go to the right, you see the bars. You have a 40% response as opposed to 20 in response, but a 32% or 33 in comparison to 14 when we're talking about remission. This is not very, I mean, this is interesting, but for me, what is most appealing and interesting is that we know residents, you guys know how difficult it is to treat a patient when the patient fail to 1, 2, 3 trials of medication, right? And this is where I think that brain stimulation in general, I'm not talking about just deep TMS, TMS as well, TDCS, now transcranial alternate current. I think at some point we need to be open-minded for that, because even those patients that failed to 3 medications, they were able to have an interesting response in the active group, like 30% as opposed to 12% in remission and response. So it is something to consider. This is a trial with deep TMS in late life depression that comes to my field, where late life depression, we don't, unfortunately, medications also, we got to a point that we don't have an interesting response. We would love to offer some relief to some patients, but unfortunately, part of our population, they don't respond to anything. And as you know, ECT for a patient older than, I would say, 70-year-old patient, a lot of comorbidities, going to ECT. I mean, I'm one of the ECT providers in the hospital. I do ECT once a week. Very effective, but some patients, they actually, it's tricky. It's really tricky, especially older adults. Anesthesia, cognitive side effects, confusion, and anyway, it's not as straightforward. So this is a study from a group from Toronto. You know, Benoit Mossan is also a geriatric psychiatrist. Daniel Blumberger, they are the authors that they study a lot of brain stimulation. Tarek Harji as well. So they then they run an interesting, quite a small study. So 25 in the active group and 27 the sham. Again, using deep TMS for older adults between 60 and 85 with depression, with MDD. And they did show the primary outcome was remission of depression in an intention to treat analysis. They also use a protocol based analysis per protocol, but we know the intention to treat would then show more real life results. The duration was 5 days per week over 4 weeks, same thing, 20 stimulation sessions. Remission rate was significantly higher with active versus sham. I think this shows in the first graph that is almost 40% of response of remission, which is interesting. It's not response, as compared to almost 12, 14 to the sham. I'm just looking at the intention to treat. If you go to the per protocol, then you have higher because you're not taking the dropouts, right? And response was even higher here. I think it's getting to 45, 50%, and per protocol much more. Number needed to treat of 4 for remission and 2.4 for response. So interesting indication, right? We have here a recent meta-analysis on anxious depression, basically taking the studies so far, just 3 studies, and they looked at, okay, so let me think. Let's try to see if the deep TMS was also effective for anxious symptoms of depression. They then went to these 3 studies that have been published, And then they looked at an anxiety outcome. And it looks like that the effect size was a point 34 with a pooled effect size of a 0.55, not the best, but not the worst as well. So in the middle, 0.5, showing that perhaps, stimulating with deep TMS could also be beneficial for patients with anxiety associated with depression or MDD with anxious distress. I think this is my last trial, and then we can open up perhaps for questions or something we can discuss. This is the very interesting trial. So that, to be honest, I was surprised because the FDA approved and the Health Canada approved deep TMS for OCD with only one trial, and that is something for me I was impressed. But when I look at the study, then I understood a little bit more. So this study was a multi-center study with almost 100, so 99 patients with OCD, but who had not responded to SSRIs and psychotherapy, and they were pretty refractory. They say in the study the iBox was high, and they had tried a lot. So these were refractory patients, and you guys know those patients with OCD refractory, nothing helps, right? Nothing. So then they exposed or performed high frequency TMS versus sham for 6 weeks. This was a longer treatment. The primary efficacy point was then the change in the iBox, the pre versus post. So baseline iBox, let's compare with the post. And then they did show that when you compare the patients across time, you have a reduction of 6 points in the iBox in the active group versus 3. So the response rate was almost 40%, and the sham was 11, respectively, the response. And in 1 month follow-up, the response rates increased to 45% in the active group as opposed to 17 or 18% in the sham group. And the graph shows exactly the numbers that I mentioned, but not in percentage, in score of the iBox. And these are the numbers in the graph shows the sample size. That they were able to keep most of the sample size. They had a dropout of 7, I think. So exciting, because I was again surprised, but I think having 40% reduction in patients refractory, perhaps that shows that it's a big deal, and it's a big achievement, and that was approved. H7 coil. And this is my last slide, just to show. This is, of course, it's a busy slide, and I don't want you to read that. But it's basically the question about side effects, right? And the most alarming side effect that deep TMS could have, it's seizure, right? So nobody wants a patient seated and having seizure, right? And it's pretty low. It's pretty low, the likelihood of having seizures. This graph shows exactly that the number of patients here in the bars, as you can see, as the time goes by, much more patients are being exposed to deep TMS. And on the this how to say, a line, you have the case here. Let me show in numbers here, because this is interesting. So from 2010 to 2020, we had almost 100,000 patients with an overall seizure frequency of this number there. And then this PFY here is interesting. It's when you control well the procedure. So the paper said that some centers, they do they perform the procedure without much control of current, interval. And when you really control that, which is in a center that you control the frequency, you control the parameters, the energy, and so forth, the seizure gets pretty low. As you can see, 6 for 10,000 for non-controlled, quote, and 2 to 10,000 for patients within control. These are promising areas of research. These are some indications that could be perhaps true in the future. Studies showing promising results, but it's still, we still need a lot of research on that. To bipolar, apathy, Alzheimer's, negative symptoms in schizophrenia and Parkinson's disease. In other promising areas, I would say it's having perhaps TMS and deep TMS post ECT. Some of you know that maintenance ECT is a problem, exposing patients to, not only the acute series, but they have to come in and do monthly or biweekly or weekly CT. It's very bothersome. So perhaps doing an acute series of ECT and a follow-up with TMS or deep TMS, it's something to consider. The theta burst, a JAMA paper just this week showing non-inferiority using theta burst as opposed to traditional TMS. Theta burst is the same TMS, but it's a different parameter where you apply a much rapid, frequent stimulation in a shorter period of time. Deep TMS, TMS, traditional TMS treatment takes around 20 minutes to 30 a session. Theta burst would take 4 minutes. So you could see much more patients using that technique. Optimize deep TMS, perhaps having 2 sessions a day. So instead of 20 visits to the hospital, patients would come 10 visits. We do that in our TMS service here. It's working really well. And then some rehab and chronic pain. I think brain stimulation has a place there. Thank you. This was a presentation. I hope I could share some exciting news about the neurostimulation world. Let me stop sharing here.
Thank you so much. Excuse me. I have a couple of questions from the chat. All right. Is the efficacy the same in patients with demyelinating diseases, for example, multiple sclerosis? Or if brain is significantly atrophied as in advanced dementia?
Yeah, these are great questions. So for patients with demyelinated, sorry, my accent gets strong with that. With these conditions, we tend not to do it. Yeah, unfortunately, there's our inclusion criteria for some patients that we actually don't know the outcomes from TMS. We unfortunately we are not authorized to expose that unless it's a trial with a specific that population, right? But I don't think there's any trial that I'm aware of, because when you go to the exclusion criteria, active neurological conditions that could affect or could be affected from the device, we don't recruit these patients unless you are testing the device for a certain indication. With regards to the atrophy, I totally agree with you. And again, this is the area that I work with. That's why I've done my training. I work with TMS for the past 12 years. And I've done most of my training and work on the traditional TMS. But now, that I work with much more seniors, we definitely see that you have a decrease in the magnetic field when you go deeper. And because the brain, it's far away from the cranial, from the bone, I would say, that's why I'm more going towards the deep TMS, where you can really go deeper, because the traditional TMS, you lose a lot of magnetic field.
Okay. And also, in terms of the actual machine, is it one with replaceable coils?
If the traditional TMS is replaceable,
are the coils replaceable?
Yeah.
Okay.
Yeah, I mean, you can replace. You can also, like for the theta burst, the device needs to be able to deliver a theta burst, but the coil is replaced. Yes, for sure. The traditional TMS, you need to change the coils, because the sham coil, if you want to run a sham study, it's a different coil. For the deep TMS, is also replaceable. The device is the same. if you want to perform an H1 coil for depression, you can, place the H1, the H7 for OCD, you then just unplug and plugged again. And the H4 for tobacco, right? For addiction, you can also place there. The coils are replaced. Yeah.
Okay. Another question. Does the occurrence of one seizure in deep TMS increase the risk of following seizures?
No.
No.
No, no. Usually when we see the seizures, what we see, it's usually patients in withdrawal, alcohol withdrawal, patients that are that are exposed to high dose of bupropion, patients that are changing medication. So usually when that factor collaborating, I mean, I'm just talking in broad terms. If a patient has a seizure disorder and you triggered a seizure disorder without any other factor contributing to that, for sure we want to control that patient. Either start an anticonvulsant, but I'm talking, most of the seizures are caused or associated with some change to patient's baseline. If you go to that papers, it's interesting. Some patients, they disclosed later on that they were in alcohol withdrawal.
Okay.
Some others were in high dose of bupropion. So it has some other effects. Yeah.
Okay. I see we have a question. Go ahead.
Hi, thank you very much for your talk. This was a really nice review of the evidence and the literature.
Thank you.
I guess my question for you is more towards your clinical experience. Longitudinal follow-up, how have you found that these patients tend to respond over time? Do you need to do more series of treatments? And maybe just for the depression, later life depression, I guess that would be my interest.
Yes, no, it's a great question. I think the long term is the problem, right? Because you can have a response, an active response, but then the patient would relapse again, right? So for TMS and deep TMS, what we do a maintenance treatment. So if the patient has a series of 20 sessions, then you can have twice a week, twice a month. No, twice a week, then twice a month, then monthly. What my clinical experience is that the relapse rate, it's lower. I don't have the numbers to tell, but patients, they relapse less when you focus on the maintenance phase. In our service, we even changed a little bit. So we give 10 sessions or 20 sessions in 10 days. If the patient responds, we focus more on the maintenance phase as opposed to the acute phase. Before we use, let's say the patient responded to the session number 8. Before we would complete the 20. Now, no, if the patient responded, we keep the remaining 12 and we invest that remaining 12 in the maintenance phase. Because we see that a big problem is the relapse rate. It's not so much the response to the acute treatment, it's the relapse down the road. So then the answer to your question is keeping the maintenance phase prolonged and as much as you can offering that. And I do feel in my clinical experience that the relapse rate is lower. Yeah.
Maybe a follow-up on that would be, in terms of the medications, do you start a new trial at the same time, the same way we would typically do with ECT?
You mean if we start a medication during the TMS?
Yeah, before starting it, do you do a switch because whatever they were on was not effective?
Yes, we tend to do that for sure. And
Okay.
and also we tend, what we really do when we have a referral, let's say from a GP or from a colleague, we do a pretty broad, pretty consistent TMS consult or ECT consult, where we go to the indications, we go to the trials, the previous trials, and we really try to give a second opinion. Have you tried that? Have you tried that? If we think that the patient is not not eligible, or if the attending could be, could try something else, we would then first ask respectfully that would be tried first. And if the indication is there, we then say, let's start certain medication. Yeah, we tend to work alongside the family doctors or other colleague psychiatrists. Yeah, ECT the same. Yeah, sometimes we see patient was tried on only sertraline, and they want to do ECT. There are no psychotic symptoms, no suicidal behavior. So let's try something first. And yeah, because as you know, TMS, it's not for everyone. Okay, Annie Charlotte, is not for everyone. If you don't have a good criteria for a subset of patients that would respond, you're gonna lose time. You're gonna spend time. Psychotic depression, no. Don't do TMS, please. Suicide, depression with active suicidal behaviors, it's not an indication. Catatonia, no. So it's important to be very rigorous, very rigor when you offer the TMS.
Thank you.
I think we had a very
Sure.
similar question, and that was about any particular medications to suggest in the maintenance phase. But I think you answered that.
Yeah, for ECT, I think the person asked about ECT, right? Following ECT, correct?
I'll just read it. Are there any medications that you would recommend within maintenance phase, similar to how guidelines suggest certain treatment in maintenance following ECT for depression? So he's asking following our TMS.
No, there's no guidelines for any specific like combination of medication for maintenance. We again, what we actually do is actually getting a good history of what the patient has been trialed on, and then make an indication. We here in our service, we tend to think that if the patient was trialed on the first class, like SSRIs, SNRIs, perhaps a TCA is a good option, nortriptyline or something like that, combined with lithium, as we all know. Nothing more than that. But if the patient has trialed on TCAs already, then we suggest other things. So there's no guideline specifically to what you should try as a maintenance phase. But yes, I think a medication is very important.
Okay, any other questions? I have one last question myself, but do any of the residents have any more questions? All right, hearing none and seeing none in the... Oh, there's another question. Great.
Sorry, just thinking about this. We had a talk a few weeks ago. I'm at UBC, and we had a talk about one of the geriatric psychiatrists who does TMS for MCI, which I think is a research protocol, because I don't think it's being funded or reimbursed by the government. Is that something, TransCanada? Is that something you have in Hamilton? Yeah.
You mean if you have a protocol with MCI? What is your question?
Well, yeah, a protocol, and then like how accessible does it end up being for patients? Is it something I have to pay out of pocket? Is it reimbursed? Is it how could we actually refer people for that if they wanted?
Yeah, deep TMS. TMS for MCI, it's only research, right? So then the patient would need to be referred to a research study. But TMS in Canada, at least in Ontario, is not covered. So physicians that we can't bill for TMS. There's no billing for physicians, and patients, if a hospital has, the patient can come in and do is our HIP billing for patients. So they would have the treatment, they don't have to pay out of pocket, unless the patient goes to private clinics. There are some private clinics in Ontario that they offer the TMS out of pocket. The accessibility is still challenging. Our waiting list here is 6 months. We have 2 devices, but for the big, the large, like like, because Toronto has some device as well, and I'm in Hamilton, so we cover up to US. So we go to Niagara. It's, I think, more than 1 million people here, and we have 2 devices. So, and there is another hospital, Hollywood something. They also have 2 devices. So, a waiting list is long. I think what we are doing now, it's offering 2 sessions a day, so the patient can come only 10 days, and then we can offer more patients. And also the theta burst now, instead of having a patient here for 30 minutes, we could have a patient for 5 minutes. And it looks like it's the same effect. The studies are showing. So we can then increase, reduce the waiting time. Yeah, but for MCI, it's amazing. You know, it would help not only with perhaps some memory issues, but also some depressive symptoms that are sometimes are correlated with patients with MCI. You're welcome.
So one final question. I'm just wondering, for smaller centers, so I would consider myself to be in a smaller center. What are the budgetary costs to start an RTMS service? Because I'm just thinking, in our particular example, we've offered ECT for ages, and now we're moving to a brand new facility, and there's going to be a suite for RTMS. And I mean, how do you go about making a recommendation for what type of machine to buy, and what sorts of funding do you need to start up a service?
Yes, I think you need the funding to buy the device. Did you buy the device already?
Someone else might have. I didn't
No,
do it.
but did they buy? Did they buy already the device?
I think so. I think so.
Yeah. So
Yeah.
the funding would be to buy the device, but also now to train. And here we have 2 full-time nurse. So the nurse, they are the ones performing. So you would have perhaps in your center, if it's a local center, we would have one nurse, full-time nurse trained to do it. So you would have the funding for the nurse, the location, and the physician. Again, we can't bill, so but you would have to have a physician there that would bill for other things. And the device, I'm not sure that the price, it's around it's from $60,000 to $100,000, I think. Yeah, it's around $100,000, I think. Yeah.
And so if we wanted to do a course to be, I don't know if the word is certified, but to be competent to provide it, do you have any recommendations? I know it might be institution based, but anything you're aware of?
Yeah, there's no standard courses that would have someone certified. I would suggest reaching out to the TMS Society. There's international Neurostimulation Society, but also TMS Society, which is a strong one, and have asked them if they can offer something for you guys. Or another thing that I would suggest, it's reaching out to big centers. Like we have one good center here. Toronto has a good TMS center, and spend 1 or 2 days or even a week doing training there. I think that makes more sense, because when you buy a device, when you purchase a device, by definition, let's say you're buying a Magstein device, which is a company, they will send a professional. That professional will train your team. The professional, it usually is a PhD or just a technician. They will show the device, showcase how it works, and show how to do it from a technical standpoint. So then you can be certified by that company.
Gotcha.
So this is built in when you buy the training as well. But to further train, indications, some tricks here and there, tips here and there, it's important to perhaps to observe or to do a little bit of a quick fellowship to one of the research centers. Yeah.
Okay.
Yeah, our deep TMS arrived. The guy stayed with us for 4 days training everyone. So
Wow.
yeah,
Okay.
so they are good on that. Yeah.
Okay. Well, thank you so much. This was so
You're welcome.
helpful. I really appreciate your time, and I think I can speak on behalf of the residents in saying that this was a fantastic session, and hopefully you'll come back again next year.
Yes, thank you all for the invitation. Have a lovely day.
Okay,
you.
bye everybody.
Thank
Thank
you.
you.